Hello, everyone. Thanks for joining me. My name is Jennifer Sloan, genetic counselor here in London, in the United Kingdom with Cooper Genomics or CooperSurgical. So I've agreed to just do a quick presentation talking about genetic counseling and what it is that we cover during a pre-test consultation, sometimes results consultations as well, with all the couples that you refer to our service, explaining our testing. So this is for pre-implantation genetic testing, kind of an overview of what we do for counseling. It's basically to facilitate informed patient consent. So a bit of an overview for this webinar today. I'll speak about the requirements for PGT-M and PGT-SR. We'll go over the terminology as well, just briefly at the beginning. And as I said before, I'll talk about some pre-test kind of requirements and what we counsel for both PGT-M and PGT-SR genetic counseling. And as I said before, this is really just to facilitate informed consent. I'll also provide just a brief, couple sentences from feedback that I have personally received and the contract genetic counselors from my team here in the United Kingdom from patients that we've counseled. And I think that's valuable for a service provider for clinics and other clinicians that you're referring to us. And also, moving away from the genetics, I think we get so focused on that sometimes. Really wanted to give some insight and some feedback to the power of empathy and the impact it does have on patients and their coping, particularly through this unique scenario that we're all being subjected to for COVID-19, and how that does impact couples as their planning for family planning has changed and somewhat delayed. So not to confuse genetic counseling with gene therapy, I do let couples know sometimes this is the first time they've been exposed to genetic counseling. They're not quite sure what to expect. Most couples for PGT-M have already been through genetic counseling clinically in the NHS with our healthcare providers there. Others perhaps have had a diagnosis of a translocation at the fertility center, and this is all new to them, not yet had an opportunity to speak to a clinician in the NHS, if they're here locally, of course, in the United Kingdom. So at the very beginning, just to clarify, and I think it's really important for clear communication, counselors, I think this is a strength for counselors. In any specialty, you'll notice that we'll have different acronyms and short forms in different specialties. So every time I introduce the new term, I will explain what that means. I will continue to have a definition as I'm introducing that new term, just to reiterate it, to improve communication and understanding throughout the session. So I do say, it's kind of an overarching, larger umbrella term, PGT, and then previously it used to be called PGD for diagnosis, and now, of course, PGT for testing. And how I explain it to couples is that, think of it as that larger umbrella and three terms beneath that. PGT-A for aneuploidy, and I explain what aneuploidy is, basically wrong number of chromosomes, any deviation from 46, as we've seen in the general population if we were to test everyone. PGT-SR, if it's applicable during this counseling session, I will go into explain what that is. If it's a PGT-M counseling session, it's a monogenic disorder, and I'll explain that to couples as well. So again, of course, structural rearrangements, that includes your reciprocal Robertsonian translocations, sometimes more rarely inversions or insertions, and then monogenic disorders, for example, cystic fibrosis, Huntington disease, well-known autosomal recessive and dominant inherited disorders, and the testing that we use for that. So what are some of the requirements? This is, I'm so sorry. This is often a question we get from clinics. This is something I'm brainstorming to work on, help to streamline throughout our process. So basically, we are asking for clinics to send us the molecular reports that's available for either the patient or the partner and other family members that have been diagnosed. If there are other reports that we have not received, we will feedback that to our coordinator, and the coordinator will ask the clinicians who are referring this couple. We'll also ask and identify, depending on the inheritance pattern, who else in the family, either the patient or partner side, either parents, or do they have an affected child or an affected pregnancy that perhaps we can get stored DNA from. So this is all part of the pre-test kind of referral process for our genetic counselor. So primarily it's me assessing these. There's also a senior genetic counselor from our US team that I've trained on UK specifics. So when there's limited family members, we can do sometimes based on the pathogenic variant when we assess the molecular report. Usually if it's a point mutation, it's fine. We will speak with our laboratory and our scientists who are designing these PGT-M designs bespoke for each couple. We also consider, obviously uniquely here in the United Kingdom, whether or not there is HFEA permission for specific disorders. If not, clinics may apply for that before moving forth. And some are, as you can imagine, quite unique scenarios that do warrant a clinical team discussion. We can have a larger team discussion with all of our genetic counselors and our medical director as well. So in contrast to the PGT-M pre-test kind of referral and inquiry process, we will also, for PGT-SR, so a wee bit different, so structural rearrangements, we're asking for a high resolution, what we call G-banded karyotype, and that's generally what's performed at either the NHS cytogenetic molecular labs or privately through TDL. I've seen quite a few of those come out of London. Our scientists then will do a calculation and personalize that unique for that patient or partner's karyotype. And we'll calculate the percentage of us identifying the unbalanced form of that translocation. That's what we're all interested in identifying, so we can confidently report which embryos after next generation sequencing have the balanced, either the balanced reciprocal translocation or Robertsonian. I'll get into that later. Basically, we're looking for right number of chromosomes, 46, with our NGS. And then our laboratories will then, once that report's written, we can notify the coordinator, who will then notify the referring clinicians that we are able to accept this. So pre-test PGT-M and PGT-SR genetic counseling, these sessions are quite different, of course, because there are different referrals for different either monogenic disorders or Robertsonian or reciprocal translocation, so we counsel accordingly. So not everything that's covered in a PGT-M session will be covered in a PGT-SR session, and likewise. As I said earlier, sometimes couples who either the male partner or the female patient has not yet had a referral to clinical genetics to talk about what is this translocation? How did it happen? Did I inherit it? Did it happen by chance? What are the repercussions for family planning, for my own medical health and management? All of that's covered in a clinical genetic counseling session. So when I speak to couples who've not had that session together, I do compromise. I can't spend 2 hours counseling everything. So I will summarize in a letter, and I provide links narrated with that kind of basic background information in an easy to follow video. It's narrated by our colleague genetic counselors in Ireland. And so that I've had some feedback that that's been quite helpful, and I put the segregation pattern diagrams with either the Robertsonian or reciprocal translocation letters. All of our genetic counselors, including myself, of course, we always take family medical history from patient and partner. We begin that at the session, seeing if there's anything else in the family history that could warrant a discussion or anything else that the couple are worried about. And we'll do the brief overview and how our laboratory tests embryo cells and how we receive those from the referring clinicians at the fertility clinics. I provide a very, very brief overview. They've likely already had a consultation with one of your consultants at the fertility center, and just go over, how our genetic testing fits into their whole cycle and care. And approximately, we aim to have a turnaround time of about 2 weeks, of course, when we receive their embryo biopsies following their IVF fertility treatment, to have the analysis, interpretation, and reporting done. So for PGT-M, we include an explanation of carrier mapping. What is carrier mapping? The accuracy of that. I am from the family history I've taken. I will identify and explain why it is that we're asking for certain relatives to be involved in the test optimization or test creation process. Answer any questions that couples may have. I explain this in a very simplistic manner. I'm not making any assumptions that everyone's had a PhD in genetics and is well versed with this, but certainly if I aim quite low in general, couples have spoken up when they do have a master's degree or a PhD. So they'll let me know and I can adjust counseling accordingly to their level of education and understanding and background reading as well. And we have a new testing platform, PGT-AI. We've had that for quite a few months, and now we have just recently, or coming up to enroll, release PGT-AI 2.0 and 2.0 plus. So we do counsel the difference between that, depending, of course, what's ordered in the patient enrollment form. We go over the accuracy. I'll also explain that in addition to testing for the monogenic disorder or that specific translocation, the unbalanced form, we also include PGT-A, which looks at common aneuploidies in all of the chromosomes. And sometimes I will explain how that happens when questioned and explain this term non-disjunction and how this usually occurs sporadically and how there is a correlation, obviously, with maternal age as well. So very rarely, I tend to tack this on at the very end. I do include this when ordered, when clinicians order mosaicism. I will give a very, very brief overview. I will reassure couples that this may not be a part of their results at all. It's more, we see it in approximately 10 to 15% of results, as you may have heard from webinars from my colleagues. When clinicians would like help from the fertility centers in explaining this to couples, if that is a part of their result, more than happy to receive that post-test referral back to our genetic counselors here at Cooper Genomics. And whenever possible, who's ever completed the enrollment genetic counseling session, either that be myself or one of the contract counselors, I will always reach out to that person first for continuity of care, which I believe is quite nice once you've already established that rapport with couples in a pre-test counseling session and enrollment session. And of course, here in the United Kingdom, we're all aware that the HFEA does not permit our laboratory from disclosing sex or gender of these embryos on the report. And obviously, there are exceptions for X-linked disorders when that's warranted. We will usually put male affected and female carriers for X-linked recessive. And then, of course, X-linked dominant is either male or female. So we would put unaffected or affected, and we don't disclose gender in that circumstance. Because our testing is the accuracy of this is very high, it's still not 100%. So we say, this is a personal decision, but we do recommend prenatal testing, that any of the embryos that are transferred following the results of our testing in our laboratory on embryos at the early developmental stage of blastocysts when they're biopsied, and we test the trophoectoderm, we do encourage couples to consider prenatal testing. If they have any further questions about CVS or amnio, the differences between those two, the accuracy, the risks involved, I do deflect all of those questions and encourage them to meet with a prenatal genetic counselor to discuss at length should they have any concerns, because if I start going there, I don't get everything covered that I need from a laboratory pre-testing counseling session. Very rarely we're unable to design a PGT-M optimization bespoke for each couple. There are some circumstances. It's very, very rare. In some circumstances, we've actually just asked for other cheek swab samples, perhaps we didn't have enough DNA, insufficient amount or quality, and we could try again. Again, that's very, very rare, but we just don't guarantee that every couple referred will have a bespoke test design offered and developed. And it's two parts. So once we have the DNA requested from everyone, we have a strict turnaround time that we set for each of our scientists for approximately 4 weeks. When that's finished, we will have our coordinator contact the referring clinician at the fertility center to let them know that we're ready to receive embryo biopsies for testing at any time. So again, in pre-test counseling, this is all part of our letter, a summary letter as well. It can be quite overwhelming, so I will regularly check in with couples to check their understanding, and I do encourage to elicit questions throughout the session. It's not meant to be a lecture, it is really meant to be a dialogue. So I do reinforce that it's very rare, but all of the embryos that we receive for testing may be affected or aneuploid. Likewise, some couples have found it hard to believe when we received all the embryos that all of them are either unaffected and euploid. So it's one extreme to the other in terms of results. It happens very rarely, but it is a possibility. These are all probabilities we're talking about. And we do provide, based on maternal age, the statistical probability for a PGT-A result, euploid versus aneuploid. And I do explain that trend. That's based on a large data set of internal results at Cooper Genomics from testing over hundreds of thousands of embryos. So we've compiled that data. I do say that the results will always be communicated by the referring clinician, and I do provide a summary report for everyone's records, the clinics, the patients, and our own records as well. Talk about the next steps in our consent form. And sometimes in some special circumstances, there may be additional consent forms that are requested. For the PGT-SR, this also automatically includes PGT-A analysis. So we do this concurrently because we use the same technology. So this is done by next generation sequencing after the embryo biopsies have been amplified in our laboratory upon receipt. I'll speak about the estimated euploid rates. Again, when I'm saying euploid and aneuploid, I will reiterate these new terms that I've introduced to couples. Euploid, I always say 46 chromosomes. Aneuploid, any deviation from that, more or less. And sometimes that can even include partials. There are limitations from our current technology. So that's important to note as well. For reciprocal translocations, our internal compiled data, so it's approximately a quarter or 25% are on average are estimated to be euploid. Robertsonians, approximately 30. Inversions and sometimes insertions are a wee bit higher, 40 to 50%. So these again, I reiterate, are best estimate approximations, kind of probabilities that we speak about pre-test. This is just a chart. I'm sure you've seen this from my colleagues' webinars and presentations previously as well. This is this well-established trend that we've known for many, many years, this correlation. The green bars are euploid, 46 chromosomes. The purple is mosaic. So again, I mentioned on average, we see that about 10 to 15%. You can see that highlighted from the percentages in the purple bars. And likewise, you know, conversely from the green bars are the blue ones, the aneuploid, wrong number of chromosomes. So an example I will highlight to couples to illustrate that is trisomy 21, also commonly known as Down syndrome. So that is a common question I get from couples. You know, do you screen for everything? Do you test for everything? And I do say that, you know, we can't possibly do that from a genetic point of view. We're focused on the specific gene and very specific spelling mistake or genetic change, pathogenic variant for the disorder referred, or if it's a translocation, the unbalanced form of those chromosomes involved, and more generally with PGT-A, looking at all the other chromosomes to see if there's any aneuploid. So kind of some, you can probably see this in bold in the bottom here, benefits and limitations. So we do go over the accuracy for PGT-SR testing with next generation sequencing. The primary take-home message from counseling here is that we are unable to distinguish through next generation sequencing healthy embryos with the correct amount of chromosomes, 46, euploid, that have a balanced reciprocal translocation or a balanced Robertsonian translocation versus the healthy embryos that do not have a translocation at all. Okay, so they're both going to appear as euploid, 46 chromosomes from our NGS results. We're unable to distinguish the two. And I do emphasize healthy because I do reiterate if it's either the patient or the partner who has had the karyotype who has this balanced reciprocal or Robertsonian translocation, I do kind of remind them that their health as well. It's not directly impacting their medical management. Of course, the repercussions are for reproductive and family planning. Very rarely when Robertsonian translocations involve, let's say, for example, chromosome 14, that comes to mind first. I will always counsel about UPD, uniparental disomy testing. I'll put a brief paragraph in that if I've counseled that, and if that's applicable, and answer their questions surrounding that. So NHS-funded patients, that's unfortunately part of the criteria for accepting the NHS funding. That's not permissible, but for privately paid patients, if they do have a chromosome rearrangement with a chromosome reported in the literature that's to occur as uniparental disomy, example 14, that is counseled and offered. Okay, so it's about really managing the patient's expectations. I will check in, after I've given these numbers. How are you feeling? Are you feeling overwhelmed? How are you responding to that number? Is that higher or lower than you expected, or did you have any previous expectations? Just to kind of elicit some feedback from couples, just to get some sense of whether or not this is sinking in or if they've just zoned out after the first 10 minutes. It's all part of effective communication, I'm hoping. So that's the skill of genetic counselors, not only taking complex genetic scenarios and terminology and explaining them very simplistically, but also compassionately and with empathy. So that's the, kind of the remainder I want to focus on, aside from the genetics and the technical point and the testing. It very much is, the second part or very much a big part of our communication is our tone of voice, our cadence, how fast or slow we're explaining something. Can we hear that couples are distressed? Sometimes when you're taking family history, that can be very, very emotive for couples. They could, I could hear someone crying. It's really hard to recall and tell me, a perfect stranger, over the phone at very early in our phone consultation about a parent who has passed away or a pregnancy loss or multiple pregnancy losses. So all of our genetic counselors are very, very sensitive to this, and we're trained. I've taken hundreds and hundreds of family histories over the years I've worked in prenatal, both in public healthcare and private, both in Canada and the UK. So check in for supports, particularly if there's been a close loss or recurrent miscarriage. How are they coping as a couple? Do they have close friends and family? Are they aware they're going through this PGT process? Sometimes couples may not inform their friends or even their parents because they feel that pressure, that burden to keep everyone updated. And although, friends and family mean well, they want to check in on you. Well, they want to see how you're doing, but after this counseling session, we realized that couples are going through quite a lot. It can be very emotionally taxing as a couple, as we're all very aware as clinicians, but also, physically taxing for the woman as well. So we acknowledge that and check support systems that they have. As I mentioned earlier, I will check in and invite some questions, elicit some response from the couples, particularly if they haven't asked throughout the session. And I will check in and just ask, has this been overwhelming? Is this too much information? We can always reconvene at another time, depending on how you're feeling. again, it's all about, establishing that rapport early in the phone call with that, taking the family history. Um, as I said before, using some empathic statements and normalization statements like "you're not alone." I've spoken to many couples with a balanced Robertsonian translocation, or who have had a child with cystic fibrosis, who have had a family member die of a sudden unexpected death from a cardiac arrhythmia, inherited cardiomyopathy, etc. It's not uncommon to feel, and go ahead and identify those feelings. You can tell that by the words the couples are choosing to use when they respond, the questions they ask. I can have a really good understanding of what's clear, what's not clear to them, and let them know that I am available, or whoever their genetic counselor is with Cooper Genomics. We're not just a one-stop shopping, not just pre-test only. We are here if you have continued questions. I do my best to direct them back to the clinic whenever possible, and I explain the reason we do this is because we want to ensure that anything coming from Cooper Genomics, either from our support team, our laboratory, our genetic counselors, is all going through the clinicians, so they are updated first, and that both the couple and the clinics are receiving the same information at the same time. So once patients understand that, they appreciate that that's the reason why we've set it up that way. And again, this is, really this whole counseling session, I say at the very beginning, is to elicit, better understanding, any questions they have an opportunity to answer those questions. It very much is a dialogue. It's meant to be a conversation, a two-way conversation. It's not unlike this webinar right now. It's not just me speaking the whole time. So it's not a form. Consent is a process. And I do let them know that there's no need to take notes. They're welcome to if they want. I will provide a summary letter and the Cooper Genomics consent form as well. So if they have any questions specific to anything in the letter that's not understood, then I invite them for that feedback as well. We'll go over possible results from testing, as I mentioned earlier, and there may be some clinic-specific information that's communicated. For example, the possibility of a failed thaw when they have a transfer set up and ready to go. And at the beginning, well, just for adjusting kind of expectations at the beginning of the phone call, I do say we have about 45 to 60 minutes together. It may not take the entire time. It may do, or a wee bit longer if they have some questions. I do supplement, learning. Some people are very visual learners. When I worked in the NHS and face-to-face with couples, a lot of our counseling is all done by phone or video conferencing. I will use diagrams. They will receive a summary letter. There's links to videos, as I mentioned before, that are narrated by our colleague genetic counselors in Ireland. And just ask them, have you had any genetics knowledge in maybe in high school, or I think it's called sixth form here in the UK. And if there's new concepts or terminology I'm entering, I will kind of I will reiterate that. And if English isn't their first language, we do have interpreters. So I've counseled people in Polish, Italian, Cantonese, several languages with the help of an interpreter, and same with our contract GCs. And so we have, a team. It's only me here in London, but we do have a team of other contract GCs, so we can accommodate if only couples are available at evening and weekends, etc. And just some brief feedback. It's been really heartwarming to hear some couples say thanks so much for your time. I really appreciate it. I understand. Thanks for taking the time to answer our questions. One couple, I think one person said, I could tell you really love your job, and that was really nice to hear. So I hope that is conveyed. That's really what we're here for. And I said, you're not bothering me. You have my email. It's in my letter. Please don't hesitate to reach out if something's not clear. If I don't know the answer, I can direct you to the person who can give that for you. And added supports for couples that are struggling with a recent loss of a child or family member. I will provide some local resources from my days counseling in the NHS as well. This is continuity of care. All of our GCs are aware of our new products, and we can be effectively answering questions that are patient specific about that or reference articles. And if there's any complex results, our laboratory director, Leonie, and I have spoken to couples directly, and sometimes couples and to clinics or just clinics alone to help explain those results. So lastly, I just wanted to focus on empathy, and that is obviously a genetic counseling strength. This video, I'm not sure if it's going to play. I'll just leave this slide up here for a wee bit if you just want to copy down that URL that's highlighted there. I don't believe if I click on it, it's going to play, but it's less than 3 minutes. It's a brilliant illustration about the difference between empathy and sympathy. And the power and impact it does have on people, particularly when they're most vulnerable, going through a very difficult kind of IVF treatment together with genetic testing and the feelings and experiences surrounding that. So it's narrated by a researcher in Texas. Her name is Brene Brown. She's had a couple TED Talks that have gone viral on the power of vulnerability and empathy. So I really, really encourage you to watch that. It'll be helpful for yourselves. It'll be helpful to your patients, and it'll be helpful in your own lives about how you connect with your family members and your friends. And it may shock you if you can connect to the bear, the fox, or the other character involved in that video. So it's really nicely done. So I just wanted to thank you all for your time very much. This is just a snapshot of London, where our new laboratory is, state-of-the-art facility. And thank you very much. My email will be posted if you have any direct questions. Thank you.